Hi, good afternoon, everyone. My name is Dr. Dominic Kakatiba. Thank you for joining us this afternoon, 3 p.m. here in Ghana, 4 p.m. in the UK, and around the globe in Canada and North America. We see a couple of participants who have joined in as well. We are grateful that you could make some time on this Friday, 17th of April, to join us for our weekly webinars. This afternoon, we are gracefully joined and being led by consultant pediatrician, honorary lecturer at the Liverpool University, works with the Mercy and West Lancashire Teaching Hospitals NHS Trust. He's in the person of Dr. Ahmad Ejaz. He's fellow of the Royal College and a member of the Royal College UK as well. Dr. Ahmad graduated in 1986. I wasn't born by then. I'm sure a couple of people joining us today were not born by then as well. So we have a legend in our midst. He's been practicing pediatrics in the United Kingdom since 1996. Currently, he's serving as a consultant since 2002. That's since May 2002. With particular interest in neonates in the trust that he serves. He served for about 6 years as the Royal College of Pediatrics and Child Health tutor, and currently is also a Royal College of Pediatric and Child Health clinical examiner. We are glad that Dr. Ahmad, you could make some time off your busy schedule to lead us with this presentation on neonatal jaundice. I know this is a topical issue, especially in the developing world, especially here in Ghana. We dedicate usually a whole week to it, a whole month towards celebrating and creating the awareness. I'm sure leading us with this presentation will bring up some of the points, especially that our pediatric nurses, our obstetrician gynecologists, our pediatricians, and whoever that is interested in child welfare and child health is joining us for today. I'm sure at the end of it, we'll learn a thing or two. So participants, kindly help me in welcoming Dr. Ahmad. Dr. Ahmad, the participants waiting for a presentation. Thank you so much. And thank you everyone for joining us. Over.
Yeah. Assalamu alaikum wa rahmatullahi wa barakatuhu. Peace and blessing of God upon you all. Thank you very much, Dr. Dominic and Humanity First Ghana and Humanity First UK, giving me an opportunity to talk on this very commonly seen topic, neonatal jaundice. My slides are moving, I trust. Slide is moving?
Yes, it is.
Yeah, thank you. So
yes.
in my this talk, I would like to discuss why it is important to discuss this topic. Although Dr. Dominic has mentioned that it's a commonly occurring problem in developing countries. Briefly talk about the bilirubin metabolism. Why are babies more prone to have this problem? Briefly discuss about physiological versus pathological jaundice, how we should assess, what we should be looking for when we're going to examine a baby, what investigation pathway we have, and what treatment we use in the UK so that you can use the same sort of practice in Ghana and other countries, wherever you're from. Briefly talk about the prolonged jaundice, the various causes, and how to evaluate and manage. So, you know that one, about 80% of preterm, while 60% of term baby develop jaundice in the first week of life. About 10% of the breastfed babies are still seen at the jaundice at 1 month of age. 10% of these babies who have jaundice will need phototherapy of some type. You know that one, the jaundice predominantly it is unconjugated. We will talk about shortly later on what is unconjugated. And I can just remind you the unconjugated bilirubin is a fat soluble, therefore it cannot be excreted in bile or the urine, and it can penetrate the blood-brain barrier and thus can cause the damage to our basal ganglia, globus pallidus, and also subthalamic nuclei, and can result is a devastating condition called current icterus or acute bilirubin encephalopathy. Just briefly remind you, mashallah, you are well aware of the bilirubin metabolism, but it's important to remind you, refresh your memories so that when you're going to deal with any case like that, you know what are the underlying, the possible causes for that. You know that one, the 75% of the heme come from the breakdown of the red cells, whether they are the normal lifespan, but in the newborn babies, the majority they are the cells who have a short lifespan, and the 25% of the heme come from ineffective erythropoiesis and also hemoproteins such as catalase, myoglobin, etc. Once heme is produced from the red cells and from other areas, then it is uptaken by reticuloendothelial system, and that's those cells, with the help of heme oxygenase, it is converted into the biliverdin, and then biliverdin is converted into bilirubin, which is the one which causes the jaundice. Bilirubin is usually is combined with albumin. We call it unconjugated, but some of the bilirubin is not combined with the albumin, but it can penetrate I mentioned to you, the blood-brain barrier, and it can cause the staining and the damage to those the basal ganglia. The bilirubin, which is attached with the albumin, that is taken up to the liver, and in the liver there are special Y protein called ligadin, and that makes the entry of the bilirubin into the liver, and with the help of enzyme called UDP-GT, is called glucuronide transferase. That enzyme converts the bilirubin, which is very toxic, to the conjugate bilirubin and making it as bilirubin diglucuronide. This is a soluble bilirubin and is less toxic. That's the natural system we have in our body. And from there, the liver, it goes into the gut. In the gut, we have a unique system over there. One is that with the help of the gut microflora, this conjugate bilirubin is converted into stercobilinogen and urobilinogen, and that is way it is excreted from the body. But we also see there's another system we have, a unique system, is called beta glucuronidase. That enzyme also converts this conjugate bilirubin into the unconjugated bilirubin, and that can be uptaken through the enterohepatic circulation back to the blood. So this is the way enterohepatic circulation can increase the level. Okay, now come to why are babies more prone? I just want to remind you the physiology in the newborn is unique after birth. The three areas over here is that the increased production of the heme by the breakdown of the red cells. The hematocrit is quite high in the newborn baby because they are in the uterus in a hypoxic state, and the fetal hemoglobin is there. Therefore, the more red cells there. Secondly, the lifespan of those the red cells in the fetus is very short, and then they are uptaken by RES system and lead to the production of the bilirubin. At the same time, the liver of the newborn baby is not that strong to handle that extensive load of the bilirubin, and thus impair the hepatic conjugation and impair the conversion of unconjugated bilirubin, which is a toxic, to the non-toxic bilirubin. So the first mechanism is increased production. Second mechanism which leads to the jaundice in newborn baby is that the microflora, the bacteria in the gut, which I mentioned to you, they convert this conjugated bilirubin into ileum to urobilinogen and strucrobilinogen, which are non-toxic substances. But because of the lack of the bacteria, this conversion is hampered. At the same time, the beta glucuronidase, it is very active in the gut, which converts this conjugated bilirubin into unconjugated bilirubin, and thus it is taken back into the blood and going back into the liver, and is called increased enterohepatic circulation. So first is the increased production of the heme. Second is decreased clearance of the conjugated bilirubin in the bowels. And third thing is increase enterohepatic circulation. There are three mechanisms which leads the baby to have a jaundice. Now, briefly talk about there are some factors which can make the babies more prone for the jaundice. There are some factors which I mentioned to you already is impaired because the liver is not that mature, but hypothermia, low temperature, hypoxia, and then the collection of blood in the scalp outside in the form of caput succedaneum and cephal hematoma, which are the common problems related with the birth trauma. In the bruises, hypoglycemia, they can impair the conjugation. Infection, of course, that can also impair the conjugation, but drugs, they can impair conjugation, but at the same time, the drugs can impair the production, the effectiveness of the microflora and decrease the clearance of the conjugated bilirubin in the gut. There are other predisposing factors are also there, and which is commonly seen, that is the insufficient production or intake of breast milk. You know that when baby A is put on breast after birth, the colostrum is in small quantity and the milk is not free flowing. So that can lead to increased enterohepatic circulation, and usually seen in the first 3 days of life. The slower passage of meconium, if a meconium is not being passed, and that can lead to increased gut transit time, and thus leads to increased enterohepatic circulation. Reduced intake of feed, weight loss, decreased urine output due to sepsis or other reasons can also culminate the problem. Just want to show this slide to you. Although I have mentioned to you the various mechanism over here is, but here we can say the breakdown of the red cells, which can be due to other conditions like maternal diabetes, and we have the problems in the red cells enzyme like a G6PD, which is commonly seen in Asian, Mediterranean, and African countries, and that can lead to the increased production of heme. Similarly, decreased conjugation is commonly seen in preterm babies. I mentioned to you, liver is not that mature, and also some genetic conditions called Crigler-Najjar and Gilbert syndrome can also impair the conjugation of the bilirubin. Now come to how we differentiate between physiological and pathological jaundice. There are some criteria which we take into consideration. The physiological jaundice usually starts 2 to 3 days of life, and it peaks at 3 to 5 days in term babies, while it peaks 5 to 7 days in preterm babies. And the rate of rise in the bilirubin is less than 8.5 micromole per mole. If you take into milligram, so 18 micromole is 1 milligram. So you can say that about a half a milligram per hour will be in your country, because your units are milligram. The conjugated fraction is less than 25 micromole. So you can say the 1.7 milligram or 15% of the total bilirubin. Physiological jaundice, which is commonly seen in babies, it resolves by 2 weeks, usually 7 to 10 days in term babies, while it resolves in 3 weeks in preterm babies. Coming back to the pathological jaundice, it is various causes are there. Any jaundice seen the first 24 hours of age, that is always pathological. Rate of rise of bilirubin is more than 8.5 micromole per mole, and conjugated fraction is more than 25 micromole. or more than 15% of total bilirubin. And if a jaundice is prolonged, then we have to declare it. If jaundice is prolonged more than 2 weeks in term babies, and if it is more than 3 weeks in preterm babies. So this is the simple criteria we take into consideration. What is the physiological, what is pathological? Briefly talk about breast milk jaundice, which is common practice in developing countries. Breast milk is a unique the gift from the nature, and the jaundice can be seen, and you need to know when we have to intervene, when we are not to intervene. So breast milk jaundice is always in direct hyperbilirubinemia. Its onset is seen after 4 to 7 days of life. The no identifiable cause is there, and it is the 3 times more likely for bilirubin going more than 205 micromole in your milligram, 0.11, 0.4 milligram. And peak bilirubin happens in such babies 6 to 8 days, while formula-fed babies, the peak is seen 3 to 4 days. You can see that the peak is slightly later than those who are on formula-fed. The breast milk jaundice lasts longer than physiological jaundice, and the resolution can take up to 2 to 3 months. This is just to briefly remind you what are the criteria. So this is, we call it, is a diagnosis of exclusion to need to make sure all other causes, which I will discuss briefly later on, are looked into that. And if they are not there, then we can say that is the breast milk jaundice. There are other causes of early unconjugated hyperbilirubinemia. I already briefly mentioned to you hemolysis. This common reason for hemolysis, it is the blood group incompatibility. It could be ABO, it could be rhesus, or minor group incompatibility. Those babies who are having a high load of the red cells, which I mentioned to you, can be seen normally in the fetus because of fetal hypoxia, but there are other conditions where polycythemia can be seen, like a baby born to a mother who have diabetes. Babies are small for gestational age. Delayed cord clamping. Yes, we are doing delayed cord clamping. This is the routine practice. But if it is delayed more than that, you can have more hemoglobin being transfused to the baby, can lead to polycythemia. And twin-to-twin transfusion, which one baby is a donor, one is a recipient. Recipient can have polycythemia. And when the red cells are broken down, you can have more jaundice. If baby has swallowed blood, that will increase the bilirubin, and also extravasation of the blood, caput or capillary hematoma, can lead to increased bilirubin. There are non-immune conditions such as spherocytosis and G6PD deficiency cases. They can lead to the hemolytic jaundice as well. We need not to forget there are underlying metabolic endocrine problems. They can also cause early unconjugated hyperbilirubinemia and also the prolonged jaundice. Now come to the what to look for when you're going to assess a baby. Of course, age of onset of jaundice is very vital. I mentioned to you, any jaundice less than 24 hours is always pathological. A jaundice which comes physiological comes a bit later, and the other condition can cause in between. That's very, very vital for that. And also prolonged jaundice criteria we already discussed. We also look for any risk factor for neonatal sepsis. If that is there, then we have to think about sepsis because sepsis is a killer, and that has to pay attention accordingly. Then we have to look into feeding type, is it breastfed or formula fed, and the pattern of feeding. How often baby is feeding? Less feeding, then baby dry and can have increased enterohepatic circulation. Then, of course, behavior and other features of sepsis are very vital. And also, if baby has early signs of acute bilirubin encephalopathy, which I mentioned to you, connectaris, the baby is very lethargic. We talk about baby is not feeding well. That if those signs are there, you need to be very, very quick to sort that problem out. Of course, blood group and rhesus factors are also vital. If mother knows the blood group, that will be easier for us to understand what is going on. Looking at a baby, if any hematoma there, any bruises there, then of course that can cause jaundice. And ethnicity, having G6PD in those areas is very vital and has to be thought for from the outset. And also any previous child who has severe jaundice and they require phototherapy, this is also one of the risk factors for this baby to have the same problem again. It's very vital to look into that. When you're going to examine the baby, so there are different ways to examine the baby. So visual inspection of the skin, gum, and sclera, that is a common way we look for the jaundice. Okay, and we try to look into bright natural light if that's available in your country. There's so much bright light is there, you don't need anything else. In a bright light, natural light, a baby yellow, you can say that one. The other thing we can do over here is you press with the finger over the skin and see that if after pressing, when the blood is moved on the side, is a white underneath or yellow underneath. If yellow underneath, then we say that it is jaundice. We need to be aware of that the changing to the skin pigmentation because of hyperbilirubinemia may be harder to see in darker skin, especially in your country or in the Asian countries. It's hard to see it. In white, it's very easy to find that one. I wanted to remind you, don't rely on visual inspection alone to estimate a bilirubin level in a baby with a suspected jaundice. That is the statement which we need to keep in mind whenever we're going to examine the baby. Of course, there are ways to get some help from that. Sometimes we use the terminology golden, yellow skin, and green skin. Again, I mentioned to you very hard, but it's mentioned over there in the textbook. The golden yellow skin, it is for a common jaundice, which means unconjugated bilirubin, and greenish skin discoloration, it is those who have high level of direct bilirubin. So that's why it's called conjugated versus unconjugated. There are olden ways to judge how much bilirubin can be in that baby when you're going to assess it. We don't use routinely in UK, but it may be useful because the resources are limited to check the bilirubin. I already mentioned to you, don't rely on that, but it can help you to assess what is going on. As you know that the bilirubin start coming in the head first, then moving on to the trunk, then going to the extremities, and in the last one, which have a jaundice, it is the hands and feet. It means that if you see any baby whose hands and feet are yellow, that means assume it the bilirubin is above 250 micromole. So you can make it divided by 18. That could be might be 10.3, something like that will be the milligram point of view. So that is the one way to look into that. It's called Kramer classification. But as I mentioned to you, this is not taken as reliable. If you feel that baby is yellow in the hands and feet, it is definitely need to do urgent bilirubin to check what is the current level in the blood. Similarly, when you're going to talk to the parents, you can tell them what is the area they should be looking into that, and they should seek help promptly. When you go to examine the baby, what we look for that? Of course, we have to look for the hydration status and the weight loss that tell you about that how much feed baby had been having, is it adequate or not. Second is to look for the how many nappies are being wet. Of course, first couple of days when baby is having colostrum, then the number of wet nappies will be less as compared to when the full blown milk is being produced, the number of nappies will be increased. So we need to follow the UNICEF's guidance from that perspective. Then of course look for the urine color. If the urine color is very dark, that indicates a jaundice is there. And also if you have bedside urine dipstick, and you look for bilirubin. I mentioned to you normally there is no bilirubin in the urine because the bilirubin it is a unconjugated, and unconjugated bilirubin is not water soluble. Therefore, there should not be any bilirubin in the urine. We have urobilinogen. That is, I mentioned to you, that is a different, that is non-toxic. Any bilirubin in a urine dipstick, it is always abnormal, indicates there is a conjugated hyperbilirubinemia. Look for the stool color. Now we see cases not that frequently, rarely, we have biliary atresia. That means the bile is not going from the liver into the gut. Therefore, the stool is light or clay colored. and that is the indicator of some biliary obstruction. Look for the features of sepsis. Clinical judgment is very vital for you. Of course, the vitals, the heart rate, the respiratory rate, the temperature, they're also going to contribute your judgment. Then, of course, look for the feature for congenital infection, torch infection. The features of rubella, the cytomegalovirus. Clinically, those features are there. They will guide you. It is a conjugated hyperbilirubinemia due to hepatitis. Now, come to the how to manage such cases. The, before I go in detail of the management, the philosophy of managing babies with the neonatal jaundice is to prevent acute bilirubin encephalopathy, we mean the coronary teres. That is our main goal for that. Because once it is established, then damage is done, and then there will be long-term sequelae for that. So, first of all, we have to ensure that all mothers after birth receive both verbal and written information on jaundice. The babies are discharged home. If mothers are told what they're looking for about the jaundice and when to seek for help, and also when baby is admitted in the department having treatment, then they need to be made aware of what is the anticipated duration of the treatment and reassure them the baby is on phototherapy, the breastfeeding, the normal cuddles, nappy care can usually continue. Early feeding to maintain adequate hydration through frequent breastfeeding and to wake the baby up for feeding if necessary. That is another key point to prevent a high level of bilirubin. Consider EBM, expressed breast milk, or infant formula if no EBM available in situation where breastfeeding is difficult to establish. So I mentioned to you, breastfeeding is a unique gift from the nature. It has to be continued, but if not available, then we have to get the fluids to prevent increased enteropathic circulation. We need to provide the lactation feeding support to breastfeeding mothers, especially those who are first-time mothers. They don't have that experience. Of course, in our countries, developing country, Pakistan, and in African countries, our mothers, our elderly ladies, they are quite experienced in breastfeeding. They are a good resource for those mothers to support them. In case there is no support available, we need to give help from that perspective. Look for the babies who are at risk of having high bilirubin. And there are three group of children who are high risk of developing high bilirubin. Those who are born under 38-week gestation. Number two, those who have previous sibling with a jaundice. And number three is mother is intending exclusive breastfeeding. And the last one is any visible jaundice in the first 24 hours. So that is what we need to tell them to the parents. They look from that perspective and then take it accordingly. Need to prevent hypothermia. The hypothermia can lead to the lung problems, the RDS, we know that one, but hypothermia can lead to high bilirubin as well. Similarly, hypoglycemia and hypoxia can have similar effect. Now I'm going to talk about what we use in UK. That is a NICE guideline. NICE is National Institute for the Care and Health Excellence. That is the body in the UK which develops the guideline, which are evidence-based or consensus-based. That is in the UK. You can have access for that guideline by Google it. Is freely available. I will now talk about what we use over here, and you can use a similar approach in Ghana or other countries where you are from. So this guideline discusses the management of neonatal jaundice in babies from birth to 28 days of life. And NICE recommendations are combined in three care pathways, which I will talk shortly. One is for pathway for care for all babies. One is those for those babies who are going on phototherapy. And the third pathway is those who have severe high level of the bilirubin and they need exchange transfusion. And also, a lot of emphasis is put on passing on the information to the parents and carers in all those three pathways. You can see this is the pathway which they had developed, and I start from here. This one, this is care for all babies. But say over there is that identify babies who are more likely to develop significant hyperbilirubinemia, which I already talked about, the 4 group of cases. Then they ask you, does baby have suspected or obvious jaundice in the first 24 hours? That's one of the criteria. If say yes, then we have to go on to the look for the baby's bilirubin, and we have to measure and record serum bilirubin within 2 hours of your first assessment. Then continue to measure the serum bilirubin every 6 hours until the level is both below the treatment line. That treatment means the phototherapy line, and also the baby is stable, and also the bilirubin level is continue to fall, that one. If baby has no jaundice within 24 hours, then we look into that. If the gestation age is less than 38 weeks, previous sibling had a jaundice, required phototherapy, and mother's intention to breastfeed exclusively. If say yes, then they say that we need to have another visual inspection by healthcare profession within 48 hours. That's very vital over here. I mentioned to you, we need to be vigilant to look for any sign of jaundice so that we can embark treatment and prevent encephalopathy. If baby has no such factors, then what they suggest over here is that need to have another look on the baby at every opportunity, especially in the first 72 hours. If baby has shown any visible jaundice within that 72 hours, then we have to check the bilirubin within 6 hours, as I mentioned to you over here. And if bilirubin is high, then we have to plot on the chart, which I showed you shortly, and see whether it is falling in the phototherapy range, or it is falling in the exchange transfusion range, or it is no visible jaundice. Then we have routine care like normal feeding, and looking for the behavior, and no need to do any blood test for that. So in summary, you need to follow these tracks over here. If baby had shown the signs of acute bilirubin encephalopathy, like baby is very lethargic, poor feeding, very weak motor reflex, that's early signs of encephalopathy, then we have to go straight away to the exchange transfusion pathway, which I will talk to you later on. I hope that makes sense to you. Thank you. So in summary, the investigation point of view, that is not for all babies investigations. In investigations which are required in all babies who have a visible jaundice and have shown any signs of the encephalopathy, then investigations will be done. And those are investigations which need all babies, like we had total bilirubin, no split, total bilirubin, blood group of the mother and the baby, womb test, and hematocrit. So that is the essential investigations for all babies, as mentioned to you, who need to go on phototherapy or exchange transfusion. Of course, when you're going to examine the baby, if you find that baby is having signs of sepsis, of course, you need to do sepsis screening. If baby is having history of G6PD, then we have to do G6PD level. And similarly, for blood count, blood film, reticulocyte, if there is a hemolytic jaundice is suspected. Again, it is not for all babies. This is all your clinical judgment, and your examination will guide you. NICE also recommend that the summary of what I told you, that measuring bilirubin in babies with a visible jaundice. Examine the baby at every opportunity within 48 hours for those who have risk factors for hyperbilirubinemia, and within 72 hours with no risk factors are there. The phototherapy thresholds are prescribed by NICE on the basis of the guideline. Okay, so before I go for that, I just want to remind you how to measure the bilirubin level. What NICE recommends over here is The nice recommends over here is always do the blood for serum bilirubin if baby has a jaundice, visible jaundice in the first 24 hours, or baby gestation is less than 35 weeks. That's only two recommendations for that doing serum bilirubin. If baby is 35 weeks and more, or over 24 hours old and have a jaundice, then some countries, they have transcutaneous bilirubinometer to measure the bilirubin level. If that bilirubinometer is not available, then measure the serum bilirubin. If that transcutaneous bilirubin level is greater than 250 micromole, then recommendation is before you act on that, check the serum bilirubin. So that's what the recommendations are. In UK, in my trust, there is no such facility available, and we just see if baby is having those criteria, we do serum bilirubin. Okay, the other recommendation over here is that don't use any of the following to predict significant hyperbilirubinemia: umbilical cord blood or bilirubin level, end-tidal carbon monoxide, and umbilical cord blood Coombs test. They are not currently recommended by NICE in UK. Now we come to the phototherapy. Okay, the phototherapy is of different types available. The different countries are different. It could be the radiation coming from the top, called LED, or fiber optic, we call Billy blankets, or fluorescent light. The different bulbs are used, they throw the light. That light goes on the skin, and that converts the toxic bilirubin, which is unconjugated bilirubin, called transbilirubin, into more water soluble, which is called cis bilirubin. So mean the baby doesn't need to metabolize that bilirubin through the liver. It is with that light, it is converted into water soluble, non-toxic, and get excreted from the body. This phototherapy reduces the need for exchange transfusion. If baby is not responding with the single light, then we can intensify. Or once the baby has very high level of bilirubin, then we have to start very high intensity phototherapy. And that can be done with the help of extra light or with the help of increasing intensity of the irradiation, depending upon what facility you have in your unit. Of course, there are some side effects, and the side effects, again, they are not any significant. So it can interfere the breastfeeding, because when baby is having high level of the jaundice, the need continuous multiple phototherapy, the breastfeeding can be affected. But we have to put NG tube down, and then we have to give the EBM so that the nutrition and the fluids continue to go on to prevent enterohepatic circulation. It can cause secretory diarrhea. If baby is very, very small, less than 28-week gestation, skin is very, very thin, they can lose the water through evaporation, and they may need extra fluid. But after 28 weeks, we don't give any extra fluid. Of course, temperature instability can come up, skin rashes can be seen, and if we don't put the eye cover, they can have a bad effect on the retina. And if baby has a conjugated hyperbilirubinemia, and we put under the light, can cause bronze baby syndrome. And again, this condition is of no importance. It had no barring over here other than the gray-brown discoloration of the skin. Now, I'll go briefly about how we decide if the significant level is going on to phototherapy pathway or is going on to exchange transfusion pathway. So this is the graph which we have. It is for different age groups from 23 weeks to 38 weeks. So that is the on the website, and on the right hand side you can see they both ask for gestation. If baby is 25 week, then the different chart is produced, is live available, and you can download that one and take it further. One thing, this blue line is over here. This is the line. Above that line is phototherapy, and this top line is any line, any bilirubin falling above this line need exchange transfusion. And one block of each this graph is we call it 10 micromole. So 5 block mean 50 micromole. I will use the word 5 block in future. That means the 5 boxes below. So one box is 10 micromole. So this is the other way. They produce a chart which you can put in your unit. Any baby who's 38 weeks or more with hypobilirubinemia, and this one talking about the age of the baby, and this we're talking about the bilirubin level. And here mentioned over here, if baby's bilirubin is this much, then action is repeat bilirubin in 6 to 12 hours. That means this is not in falling in the phototherapy line. This one, that this level is there, and then consider phototherapy and repeat bilirubin in 6 hours. This level is there, then they say that it is already in the phototherapy line, start phototherapy. And if we have these levels over here, then mean baby level is quite high, we need to consider for exchange transfusion unless level falls threshold while preparing. So what we do over here is, if somebody is having the level, we start the multiple phototherapy, and then while you're preparing for exchange transfusion, of course, there are other ways as well, which I will discuss later on. So this is the chart which we use over here to guide us where the level falling, if it is in the phototherapy line, or it's below the phototherapy line, or it is falling the exchange transfusion line. Okay, so once somebody has gone on to the phototherapy pathway, and then the recommendation, what NICE has given to us is, I just want to go through with that. They say that is serum bilirubin level rising rapidly more than 8.5 micromole per hour, which I mentioned to you, 18 micromole is 1 milligram. You can say is about half a milligram per hour or more, and or the bilirubin level is a 5 boxes, the 50 micromole I mentioned, 5 boxes below the threshold for which exchange transfusion is indicated after 72 hours. If say yes, then we have to start continuous multiple phototherapy. Don't interrupt for feeding. You can put NG tube down, EBM can go. If mother is not breastfeeding, formula milk can go in and give the feeding. Continue administering if the baby is nail by mouth, intravenous fluid if somebody has the bowel issues. Continue lactation feeding. Mother continue expressing the milk and giving it, and monitor hydration by daily weighing of the baby and assessing the wet nappies. Then check the bilirubin 4 to 6 hours after starting phototherapy. So once started phototherapy, multiple phototherapy continues, check the bilirubin 4 to 6 hours after starting therapy, and then every 6 to 12 hours if bilirubin level is stable or falling. That's very, very important over here. If serum bilirubin is stable and falling, then we say that if serum bilirubin level is 5 boxes below the threshold for exchange transfusion, say yes, then we step down to single light. If no, then we continue phototherapy, the bilirubin goes on that. If baby bilirubin is not rising rapidly more than 8.5 micromole or a half milligram, or not falling within 50 micromole of 5 boxes below the threshold for exchange transfusion after 72 hours, then start single phototherapy. And that phototherapy will having some breaks for breastfeeding and a nappy change care and also the cooling. This is allowed because the level is not at high. Then check the bilirubin 4 to 6 hours after starting phototherapy, and then every 6 to 12 hours if bilirubin level is stable and falling, just like the pathway I mentioned to you. If bilirubin level is stable and falling, then and a level has gone at least 5 boxes below the threshold phototherapy, then we go on to check the bilirubin. We stop the phototherapy and check the bilirubin 12 to 18 hours after stopping phototherapy. If it's not falling that much, then need to continue the phototherapy till we get the right number over here. One thing over here I want to mention over here is that this is the time that when you're going phototherapy, do the investigation, which I already mentioned to you. That's only time when we have to do investigations. Other than that, we don't recommend any investigations unless there are other reasons behind. Okay, so that's a graph once again. That's to remind you the one box is 10 micromole, 5 boxes is 50 micromole, and if anyone is following the exchange transfusion, then the exchange transfusion, if somebody is close to the exchange transfusion, then we start with the high level of phototherapy. Anyone below phototherapy, 5 boxes or more than 5 boxes below, then we stop the phototherapy and check the rebound bilirubin at 12 to 18 hours later. Okay, now we come to the, I'll talk about that one. Okay. Yes, there are some factors that influence the risk of connectors. A is the bilirubin is greater than 340 micromole. In your country, I've calculated 18.9 over 19 milligram. In babies who are 37 weeks and more, they are the babies who have high risk for connectors. Number two, the rate of rise of bilirubin is more than 8.5 micromole or more than half milligram per hour. The third thing is any baby who has started showing the features of bilirubin encephalopathy. I'll also showed you before you, baby sleepy, lethargic, poor feeding, and also the motor reflex is poor. That means that first phase of that encephalopathy has started at that time to do intervene by multiple therapy and prepare for exchange transfusion. This is a nice recommendation. If somebody is having the features of the connectors or the level is in exchange transfusion, the recommendation is initiate continuous multiple phototherapy and use intravenous immunoglobulins. I don't know whether it's available in your country, maybe in the bigger cities. Recommendation is that we use IVIG, 500 milligram per kilogram over 4 hours, especially for those babies who have rhesus incompatibility or ABO incompatibility, because this IVIG will block the antibodies which are destroying the red cells, so the production of bilirubin can be hampered. If baby has bilirubin level remains above the threshold vaccine transfusion and or showing the signs of acute bilirubin encephalopathy, continue multiple phototherapy and perform exchange transfusion. If bilirubin level is falling below threshold for exchange transfusion, then follow the phototherapy pathway. So that's what we normally do over here is very rarely we have to use the exchange transfusion. If baby needs exchange transfusion, we transfer to our tertiary care with a regional unit. But very rarely that's the case over here is we start multiple phototherapy, we give the intravenous fluids, we give the feed and check the bilirubin very regularly, and we see there is significant improvement. IVIG, I already mentioned to you, that is for those cases who have rhesus incompatibility or ABO incompatibility or other minor blood group incompatibility. And that is a dramatic improvement in the level and reduces the need for exchange transfusion. Already talked about that one. They say that, just want to remind you, that not to be used in babies who have a high drops. Okay, and also anecdotally less likely to be successful if baby is anemic. The hemoglobin is less than 100 gram. IVIG could increase the risk of late transfusion. It's open to controversy. Now come to the exchange transfusion. I don't know how often your units do that one. Nice recommend in the tertiary level, the center where we transfer babies. They recommend over here single volume transfusion, mean the 85 to 90 ml per kilo of the blood is being used, and they take it further. This is done for those whose bilirubin level indicates in necessity or clinical features of connectors over there. During exchange transfusion, NICE recommends don't stop continuous multiple phototherapy, perform a single volume exchange, use albumin priming. I mentioned you albumin binds the unconjugated bilirubin, and that is less toxic to the brain because anything bound with albumin does not cross the blood-brain barrier and can prevent the damage to the and routinely administer intravenous calcium over here. Following exchange transfusion, maintain continuous multiple phototherapy, measure cerebrobilirubin level within 2 hours, and manage according to the threshold table and treatment threshold graphs, which I already shown you. So, what are the key recommendations for the care of all babies over here is that basically is identify babies who are more likely to develop significant hyperbilirubinemia, such as those gestation age less than 38 weeks, previous sibling with neonatal jaundice, those mothers who tend to exclusively breastfeed, and those who have visible jaundice in the first 24 hours. Those are areas which we need to focus on that to prevent significant hyperbilirubinemia. Coming back to the prognosis, prognosis is excellent for the babies who have the high level of bilirubin, and brain damage due to kernicterus remains a true risk, but the apparent increased incidence of kernicterus in recent years may be due to misconception that a jaundice in healthy full-term infant is not dangerous and can be disregarded. That's why we reminded over here is babies are going home from the maternity unit. Parents need to be taught, educated, what to look for. If they find any jaundice is there, they need to seek medical help. But in this country, if we don't tell them, baby go home, and nobody is looking at that baby, and the level can increase and can cause damage. Mortality and morbidity due to kernicterus is significant. Okay, what they say over here is in North America and European, the incidence ranges from 0.4 to 2.7 cases per 100,000 births. And death from physiological neonatal jaundice per se should not occur. The death from kernicterus, they say, particularly in countries who have less developed medical care system. And one study I was reading, a small study done in rural Nigeria, 31% of the babies with clinical jaundice tested had G6PD deficiency, and 36% of these cases died with the presumed kernicterus, compared with only 3% of the infants who have a normal G6PD level. This just to briefly remind you about what are the early features of early and established features of kernicterus, which mean bilirubin and encephalopathy. I mentioned to you early features are lethargy, poor sucking, hypotonia, maybe very sleepy and stuporous, and also weak motor reflex. And when somebody has established kernicterus, you can see they have hypotonicity, they have opisthostonus. You see the picture over here. They have pronation spasm of the arms. They can have a fits. They can have apnea. They can have temperature and high-pitched cry. And these are the babies who almost always suffer permanent brain damage. That they have reduced hearing. They can have dystonia. They can have athetoid cerebral palsy, retarded psychomotor retardation, and paralysis of upward gaze. Just briefly talking about prolonged jaundice. Okay, that's another problem which you come across. Prolonged jaundice, I mentioned to you, the babies who are term babies, more than 2 weeks jaundice is prolonged, and preterm, less than 37-week gestation, more than 3 weeks, we call prolonged jaundice. The causes are the similar, which we talk about in the unconjugated hyperbilirubinemia, which is most commonly seen, and it could be more serious. Hemolysis, sepsis, polycythemia, extravasated blood, enterohepatic circulation, and endocrine metabolic causes, they are important over here is the hypothyroidism, we can have galactosemia, hypopituitarism, and reduced cortisol, and of course, the amino acid disorder, they can cause that sort of problem. The conjugated jaundice, we call cholestatic jaundice. There is the top of the list over here is the sepsis. All will look for that. Sepsis can cause unconjugated and can cause conjugated. We can have biliary obstruction, and the commonest one we see here is biliary atresia, and neonatal hepatitis syndrome. The torch is on the top of the list. Metabolic disorder, galactosemia, they can cause unconjugated, they can conjugated. And similarly, amino acid disorders can cause conjugated and conjugated bilirubin. Of course, alpha-1 antitrypsin deficiency, cystic fibrosis, they are the rare disorders which can cause cholestatic jaundice. What we do over here in UK, the recommendation is we do different type of investigations on the basis of the condition. And what are the results of the initial investigation? We call it stage 1 assessment. Stage 1 assessment means the baby has clinically detectable jaundice, but baby is otherwise well. There could be baby with the breast milk jaundice. So, but I mentioned to you that diagnosis is diagnosis of exclusion. You need to make sure no other condition is existing before you label that baby having breast milk jaundice. The recommendation over here is take a full history and examination, asking for the urine color and also the stool color, baby is breastfeeding or not. And the bloods, same blood investigations, which I mentioned before, but on the top of that, we add LFT and thyroid function, and also urine reduces substance, which you can do with the clinic test available. And also we do urine culture if there is a high index of suspicion for UTI. If baby is unwell, irrespective of the type of hyperbilirubinemia, consider sepsis and metabolic disorder such as galactosemia. That's very, very important on the top of the list. Baby can be very ill. And if you have any doubt, change the milk to pregestamil, which is for galactosemia, while you're waiting for the confirmation. Consider vitamin K, because such babies can have clotting abnormality. Please give leaflet to the parents if you have any leaflet or some information, so that they are aware of what assessment is required, what observations are required for prolonged jaundice. Once you have got the investigation result back, then we have this pathway over here is, if the total bilirubin is less than 200 and conjugated fraction is less than 25 millimole or less than 15% of total bilirubin, then our pathway say discharge the baby, no follow-up required. The baby may have simple idiopathic jaundice or could be breast milk jaundice. If any signs of hemolysis is there, clinically on the history, and unconjugated bilirubin is more than 200, then we have to go to 2A, stage 2A investigation, which I will show you shortly. If conjugated fraction is more than 25 micromole, or the fraction is more than 25% of the conjugated bilirubin, then we have to follow the stage 2B investigation, which I show shortly. So this is stage 2B investigation. Sorry, this is a investigations for unconjugated hyperbilirubinemia. So you got the level is more than 200, baby is otherwise well. Look for G6PD level, if not already done. Then look for Caliput, the enzyme which causes galactosemia, and that is which we sent, although we have already sent a urine for reducing substance, because sometimes the level is very, result is very equivocal. Then we check for 9-AM cortisol, look for the reduced cortisol level, which can cause the prolonged jaundice, and urine microscopy and culture if there is a high index of UTI, and also look for urine organic and amino acid for any metabolic disorder. In the UK, cystic fibrosis is very commonly seen. Therefore, we do the screening at day 5 of life. If the Guthrie test has gone, that is called Guthrie test, then we follow that route. If test is positive, then we take it further. Stage 2A investigation, this is for those who have conjugated hyperbilirubinemia, we call cholestatic jaundice, and that means we have to rule out any obstruction to the biliary pathway. That could be due to biliary atresia or could be choledochal cyst or something else going on. We need to do ultrasound scan of the liver urgently, and that to be done. Baby is kept fasting, not with the feeding. When you give the feeding, the gallbladder will be contracted. The ultrasoundologist will not be able to see the gallbladder. It has to be fasting for at least 4 to 6 hours. We give feed when the ultrasound is being done, and they can watch it. Then hydra scan of the liver, if any doubt is there, that is, I don't know whether you have facility or not. This is where we confirm that if a baby has biliary atresia or not. We do the TORCH screening, that is look for neonatal hepatitis syndrome, look for TSH if not done before, 9-m cortisol if not done before. We also consider short synaptin to look for hypoadrenalism and also hypothyroidism. Liver functions, if not done before, along with UNE and bicarbonate, and clotting screening. I mentioned to you, if somebody has hepatitis, they can have deranged clotting. And all other tests which I already mentioned to you, that they can be considered if 2A investigations are required. Stage 3 investigation, that is done by the specialist liver unit. We confirm the stage 1 and stage 2 investigations. And if somebody has a cholestatic jaundice over there, we transfer the baby to the tertiary hospitals with the expert in the liver disorders. They manage that one. And these are the things they do over there, including liver biopsy. So in summary, the care of the babies with a prolonged jaundice, look for the pale chalky stool. That's very, very important there. And also dark urine that stain the nappy. If urine is not a dark, okay, if stool is not the bilirubin containing, that's concerning, and the urine is dark, that is concerning. Measure the conjugated bilirubin when you are having prolonged jaundice, not the total bilirubin. No need to subtract from that. Conjugated bilirubin fraction is very vital for that. Check full blood count, check the mother's and baby's blood group, and Coombs test if not done before. Carry out a urine culture if there is a high index of suspicion, and ensure the routine metabolic screening. Look for congenital hypothyroidism is done, and also looking for galactosemia. Always look out obstructive jaundice is very vital to look for any obstruction such as biliary atresia, because the surgery has a better results if the Kasai operation which is done for biliary atresia is undertaken within the first month after diagnosis. So this is very, very important, the time critical intervention. So briefly, scenarios are there. If a prolonged neonatal unconjugated bilirubin more than 200 micromole or more than 11.1 milligram, with the negative results of the investigation, which I already explained to you, and baby is not breastfeeding, then it could be Crigler-Najjar syndrome. And this time, if baby is high level, then we have to discuss with the liver unit. If unconjugated hyperbilirubinemia is there, that continues to come down steadily in a breastfed baby who is otherwise very well and thriving, and is almost certainly breast milk jaundice. So that's the way we can diagnose. I mentioned it before. Make sure that the baby has no other reasons for that, and thus such baby does not require further investigations. And the good criteria we'll take over here is baby is well, baby continue putting on weight. So that is the hallmark, that is the breast milk jaundice. In the absence of breastfeeding, similar babies with a prolonged but decreasing unconjugated hyperbilirubinemia who are otherwise well and had the above screening investigation negative may have idiopathic or exaggerated physiological jaundice, which is prolonged. This is again could be due to a condition called Crigler-Najjar type 2 or Gilbert syndrome. And the last one, if in doubt, always discuss with a specialist liver team in your country rather than endlessly repeating bilirubin, as this may take several weeks before complete resolution happens. So take home messages from today's talk is that focus should be on early detection and prevention of severe jaundice and current icterus. Inform parents and the carer about what is jaundice, what look for when the baby is jaundice, feeding, the importance of feeding, frequent small feeding is very vital, and red flag of severe jaundice. If jaundice has involved the hands and soul, the palms and the soles, that mean is already very high level jaundice. need to get immediate help, and what to do from that perspective. Examine the babies in natural bright light, not in the room light. Skin color and serum bilirubin don't always correlate, I mentioned to you, but of course, the facilities are limited. They can give you some guidance what goes on. Always investigate any baby with a jaundice occurring within first 24 hours. It is always pathological. Always consider neonatal sepsis because sepsis is a killer. If you are investigating, all the baby should have group and cum, blood count, film, reticulocyte, along with bilirubin. Split bilirubin only if prolonged jaundice, not as a routine investigation. Routine investigation is just the total bilirubin. When a prolonged jaundice, you ask for split bilirubin, look for the conjugated fraction. Look for signs of conjugated jaundice, which I mentioned to you, the pale color stool and dark color urine. Thank you very much for listening. I'm very happy to take the question if you have.
Excellent. Thank you so much, Doc, for an excellent job done. This has been great. We really learned a lot. So, just for your updates throughout the presentation, we had about an average of 190 people joining today. Maximum numbers of 107, 207, sorry, 207. And at start, we had about 82. So really a great turnout. There were some questions they put in the chat box already. Those I could respond to by way of general messaging. I did. Please. I would read the rest of particular. One was some participants asking if you could make the slides available after this so that then they could use it in their studies and revision. So if you are happy to make it available, you could put it up on our WhatsApp. Fantastic. And then I'll be glad to share as well with all the participants as well. Great, and thanks a lot. So we open the floor for questions. I've made a couple of contacts, co-host, so feel free to unmute yourself, i.e. Dr. Matilda, and those of us with the Humanity First Ghana as well, and everyone. So feel free, once you've been made a co-host, if you want to have some input, comments, feel free to unmute and then talk. However, participants, if you want to ask a question, make a contribution, just electronically put up your hand. I'll be happy to unmute you so that we have a good discussion on this excellent and legendary lecture that we've had from Dr. Ahmad. This has been great. So, guys, over to you. If you have any question, just put up your hand. I would glad to unmute you. Co-host, feel free to unmute yourself if you want to talk.
Looks like my lecture has been taken on board by everyone. That's great.
Yeah, absolutely. It's been great.
There's a hand there.
So, yeah, sure. Aisha, I've asked you to unmute. Please go ahead. Aisha, I've asked you to unmute. You could just tap on unmute and then you'll be able to talk. Aisha, if you're having difficulties, I could make you a co-host. I've just done that now, so you should be able to unmute yourself. Can you tap on the unmute button?
Yes. Initially, it wasn't working, but thank you very much.
Great.
Please, I want to ask Doctor concerning breast milk jaundice. Currently, there is a rise in mothers undertaking cesarean section. And as you can see, sometimes it's puts a tone on the mothers, and then at the end of the day, you see that the baby is being admitted to the NICU due to this breast milk jaundice. So I want to find out maybe from their end, what are the best things they put in place in order to curb this? Because cesarean section, early initiation of breastfeeding and jaundice is a challenge in terms of rendering service to our mothers. Thank you very much for a very wonderful presentation.
Yeah, Thank you very much, Aisha. Yes, it's a very challenging for the mother, who has undergone for cesarean section and the milk is not available. In our country, we have, the donor milk. If parents are uh, uh, they have wished that before the delivery they would like to have exclusive breastfeeding, then we offer them that milk is available, and donor milk can be used to give the baby feed. Because early feeding, I have mentioned to you, and frequent feeding is the key to prevent the increased enterohepatic circulation. So that's the way forward over here. If somebody is no donor milk is there, the EBM not there, then the other possibility is if parents can't produce the milk, then we have to consider the formula milk. So calories are very vital, fluids are very vital. So that is what I will suggest. This is what we normally do over here.
Thank you very much.
But
Great.
continue expressing as soon as mother is waking up. She's very passionate. Baby is born, baby is well, looking for the feed. That passion goes in and give her, express any apparatus. We have, the pump available. They express the milk and then send to the neonatal unit, and they give the baby the feed through the either with the bottle or through the NG tube. So that's what we normally do over here.
Jazakallah for the answers.
Sorry, say again.
I said Jazakallah for the answers.
Okay, you're welcome. You're welcome.
Fantastic. Great. So, anymore, don't feel shy. Just like Aisha has done, kindly electronically put up your hand. I'll be
We got
happy to
another hand.
unmute you.
Yeah.
Yes, fantastic. Yeah, I just saw that as well. Yes, Dorcas, please go ahead. I've asked you to unmute yourself. I don't know.
Okay, hello. Thank you so
Okay,
much.
great.
Hello.
Yeah, please, my name is
We
Dorcas.
can hear
I'm
now.
talking
Please go
from.
ahead.
Okay, please. I want to know the current management of breast milk jaundice. If a baby is diagnosed with breast milk jaundice, do we have to stop breastfeeding or we can continue?
Yeah.
Thank you.
Okay. Yeah. Thank you very much. I mentioned to you, breast milk is a unique gift from the God, from the nature, right? So that is a very vital food, source of fluid for the baby. It should not be stopped. There's no recommendation at all in the UK. I mentioned to you, if somebody has a jaundice, my grandson is gone 5 months old, he has a breast milk jaundice. We never stopped it. What we have to do over here is, if jaundice is prolonged, just make sure stage 1 investigation are done, make sure there's no other reason behind, and the level is not at high, and the other investigation, they are normal, continue breastfeeding. If baby is putting on weight, continue breastfeeding. That's what we normally do here, and usually resolved by 2 to 3 months of age. We don't stop the breastfeeding at all. I hope that answers your question.
Yeah, hopefully it does. Otherwise, you can always come back once you've been unmuted. Any more hands? Kindly put up your hand. Co-host, if you want to talk, feel free, unmute yourself. Go ahead, and then, yeah, we have a good time. Just as we wait, of course, I should let participants know that at Ghana Medical Help, we've been having these webinars week in, week out. Of particular significance at the beginning of this month has been the partnership with Humanity First Ghana and Humanity First UK. So you see, the last two presenters are experts in the UK. They volunteer for Humanity First UK, and they do come in with Humanity First Ghana to provide some mentorship, some equipment donations, and some teaching sessions, as well as many other evangelism points that they do for the Upper West Municipal Hospital and recently the Upper West Regional Hospital. So we are glad that we've had their partnership, and just like we've seen with the last two webinars, we've had consultants who are not in Ghana joining. Hopefully, at any of the days that they are available, we are happy to, just like we do every week, to have them join us for these afternoon lectures. And to also crave your indulgence so that you get to know that these are recorded as well. Just like people are asking for the slides, when they are available, I would post them. And then the webinar recording as well will be made available on the YouTube channel. Just look with me in the chat box. You find all the links there for all the webinars we've been doing over the past 5 years. They are all on the YouTube channel. So if you miss it, if you had network problems, including the last 2 that we have done, you access them there and you are good to go. We also make the slides available. So thank you so much for joining us. If you have a question, a point, please raise up your hand. I'm happy to unmute you so that you can make your contribution. It just makes the presentation richer. If you have some local dynamics to share, some form of what we call APROTech, what you do in your locality, what the pediatricians are doing in Ghana, in the Upper West, elsewhere, what the pediatric nurses, what the physician in practice in pediatrics are doing, please feel free. Don't feel shy. It may just be a learning point for all of us, even including our consultants. So never feel shy. Put up your hand. We'll be happy to unmute you. Co-host, feel free, unmute yourself and go ahead. So we'll be waiting for you.
While we're waiting for the hands going to be raised, can I remind that the next week there will be a talk on anemia and pregnancy. Am I right? This was the agreed. So that will be obstetric talk. And week after, we will have a neonatal again. Every fortnightly neonatal topic, and every fortnightly alternating, we have obstetric topic.
Absolutely. Thank you so much. I was waiting to give that at the end. It's good it came before we lose some people. Totally. Great. So Aisha's hand is up. Please go ahead, Aisha. You are actually a co-host, so you don't need to raise up your hand. So you could just go ahead.
Thank you very much. Please, a small recommendation that I want to put across.
Okay.
Please, in terms of detection of jaundice and treatment, most of the times healthcare workers miss some aspects in terms of treatment, because sometimes we have the classification of jaundice being pathological and then physiological. Sometimes you have a mother coming to the clinic and differentiating pathological and physiological, sometimes we miss it, because we may say that maybe pathological has to do with within 24 hours. When someone comes after, we sometimes will tell the person that go and breastfeed and then do a sit bath. Some health personnel will say do a sit bath, and in this case, putting a baby under the sun. But what doctor have elaborated, it means that we should try as much as possible to find the underlying cause before we can define either being pathological or physiological, so that we don't end up letting the child go into kinetoros, because once you push the woman away and say this is pathological and physiological without doing underlying investigation, and it means when mother go home, the baby can get kinetoros out of that. So I'm just entreating all personnel here that once we see that, we should be able to do those tests to rule out any other thing before we would allow the mothers to go. So thank you very much.
Yeah, it's absolutely right, Aisha, what you said it. NICE doesn't recommend any treatment with sunlight. We need to have a special spectrum radiation which can convert the trans bilirubin to cyst. Not all rays coming from the sun will make it. The risk of connectivity is very high if baby is not brought to the medical attention. That's very, very vital over there. Thank you very much, Aisha, reminding us.
Excellent. Thank you so much. Any more questions? We have about some 6 minutes. We could take some few more.
These charts are available, and I request that every unit, wherever you work, you download the chart and put the gestation, and you see the chart will be different for different gestation, 23, 24, 25 week. And that's where you can, no need to print it, just on your laptop or in your computer in your hospital, put that one and give you what is the phototherapy line, what is the exchange transfer line, and that's where you can manage in your unit.
Great. Thank you so much. I don't see any hand up. I suspect there are no questions.
Yeah.
So on behalf of everyone here in the Upper West, in WA, on behalf of all the participants who've joined in today and all of us who have benefited from this legendary presentation, I want to say a huge thank you, Dr. Ahmad.
Welcome.
This has been excellent. This has been educative, and I'm sure it will inform practice. And how much more effect and benefit can it be than to help the babies to survive and the future leaders to lead Ghana to a bigger destination. So we are really, really grateful. May Allah bless you and bless all your efforts. Amen.
There's one question, one hand, Dr. Dominic.
Yes,
Dr.
sure.
Ali. Dr. Ali has raised hand, if you allow him.
Yes, absolutely.
Yeah.
Yes. So, Dr. Ali, yeah, right. So, ask to unmute. Yes, Dr. Ali, please go ahead.
Okay. Yeah, good afternoon. Assalamu alaikum. Please, I wanted to find out if there is CPD attached to this presentation.
Yeah, unfortunately not. We have not registered it for CPD. However, there is a CPD running next week, which has 20 points. We could put up that link as well for you too. In the future, I've had discussions with Dr. Zach. It does cost some money to be able to register over 2,000 Ghana CD. So possibly if we get people coming forward to be able to support us to do this, that should be possible. I think it's about 2,800 for both provider accreditation and program accreditation. I've registered a couple of them, but for this particular webinar, it's not.
All right, thank you very much. All right. And did he say we were going to get the slides?
Yes, I will share it.
Thank you so much.
Absolutely. So if you look in the chat box with me, I've put in some links there.
Okay.
Once you are on any of those and Dr. Ahmad makes the slides available, I would share them on all those networks. I'll put it just for the benefit of the doubt again, up maybe those who joined over the last 5 minutes, they may not have seen that. So I've just put it back in there. Any of those you would find both the webinar recording and then the CPD, not the CPD, was it? The PowerPoint presentations. Thank you.
Thank you so much.
All right. So thank you so much, participants, for joining us for today. And we cannot just thank you enough, Dr. Ahmad. This has been great. God bless all of us. Next week, we'll do anemia and pregnancy, like Dr. Ahmad mentioned. Same time, same delivery medium, same link. It never changes. It's the same link. If you have it, you can keep it. The same meeting code, the same meeting password. We use the same one. So whichever means you join today, you can just keep that for all the subsequent webinars. It doesn't change. But we advertise same as well. So thank you. Take care and God bless all of us. Bye-bye.
Thank you very much.